everyone. Today here I have Chris Stein, who is a nurse anesthetist, and he's willing to talk to us. So how are you, Chris?
I'm fantastic. How are you today?
I'm amazing. So just to start with, what inspired you to go into nurse anesthesia?
So my trek to becoming a nurse anesthetist is sort of a long one. And probably what you have to do is go back to the beginning. From the time I was a very young man, I grew up during the time of the Vietnam War. There was, a little bit of political unrest. And I always knew that I wanted to do something to help people. I kind of felt that was my path, that I was going to help people somehow. And long story short, I thought I was going to get a college scholarship. I came from a family of 7, not a lot of money around. Thought I was going to get a scholarship for wrestling because I was pretty good at that time. That didn't happen. So I wound up going in the military for 2 years, and I served the country so that I could get my GI Bill. When I got out of the Navy, I was married. And at that time, my wife and I both were in the Navy, so we went to college on our GI Bill. I was at the time working as a mechanic in an aluminum foundry, and I was taking engineering courses. My wife was taking physical therapy courses. She wound up switching into nursing, and I realized watching her take her nursing courses that I think I'd rather fix people than fix machines. And so I pursued a degree in nursing at the University of Wisconsin in Milwaukee, graduating in 1985, and wound up working at Children's Hospital in the pediatric ICU. After a year there, my wife, who's from California, we decided to move back to California, and we both took jobs at UCLA. She was working in the neonatal ICU as a neonatal nurse, and I was hired in the pediatric ICU at UCLA. During my course there, I was in the ICU for about 5 years. I was the assistant nurse manager of the pediatric ICU. During that time, my wife had pursued a nurse practitioner degree. She received her master's in neonatal nurse practitioner. So she was working as an advanced practice nurse there. And I was considering my options. I was either going to do, I was considering a pediatric critical care nurse practitionership, which they offered at UCLA. I would have been a nurse practitioner on the cardiothoracic team probably. But one of my mentors in the ICU is Dr. Judith Brill. She's an anesthesiologist as well as a pediatric intensivist. She encouraged me to go into nurse anesthesia. It happened at the time that I was also part of the negotiating team for the nurses for the union. And I met the nurse anesthetist that represented both the UCLA program of nurse anesthesia, but she also represented the nurse anesthetists in the negotiations for their salaries. She invited me down to the operating room for a day of observation. I got to watch her and a second-year student, along with an anesthesiologist. They were doing a hepatectomy, along with Dr. Busatil, who was the chief of transplant surgery at the time at UCLA for livers. And I saw the command that both the student had, the nurse anesthetist, who was really, if the student struggled, would teach and pick up the ball, and the consultation with the anesthesiologist, the way the team worked together, the command they had on a difficult case was amazing. And I was hooked. There was just no looking back for me. There was not even a question that I wouldn't become a nurse anesthetist, because it was fantastic. I can still remember how excited I was when I came out of that operating room and said, I think this is what I can do. And that was in 1992. I immediately applied, and it just so happened that a person had dropped out of the application process. So there was an empty spot open. At that time, they only took 10 students. They would have over 500 applicants from across the country. They took 10. One of them dropped out. They went to Wayne State, and I picked up that slot. And so I started a year earlier and I finished in 1994.
Wow. That's quite the journey.
It is.
Yeah. So let's talk a little bit more about you and actually about your patients in general. Do you have a patient that you will always remember, someone that is very memorable, you'll never forget him?
Through the course of my nursing career, I have kept a file. And there's not too many people who know about this file, but it's a file of all my favorite memories, moments. Probably the first one that is in that file was a card that I received student at General Motors, and I was working as an intern. It was a summer internship that I was doing in industrial medicine, because at that time I had considered becoming a nurse practitioner in industry. Well, I was working there, and a person came in crisis, and they threw a injectable vial of glucagon and said, "If I become unconscious, give me this glucagon." So I immediately, did as instructed, because the patient then collapsed, and I resuscitated them. And they gave me a card later, and they said, "Thank you for saving my life," and all that kind of thing. So over the years, I've saved many letters, cards, and I can't pick any particular one, because there have been so many times where I've interacted with patients. In my 7 years in the pediatric ICU, I took care of a lot of critically ill children. Some made it, some didn't, but really took care of many of them for a long period of time. As recently as last month, in the pain practice that I worked in Northridge, I take care of patients who have intrathecal infusion devices. One of my patients passed away. She'd been sick for a long, long time, and I went to her funeral. Through the course of my career, anesthesia is this beautiful thing where you get to meet people for a short period of time. They entrust you with their life. You put them to sleep. You wake them up. You may or may not see them again. Pain management was one of those types of practices where I developed relationships, and I have patients that I've had under my care for as long as 20 plus years, 25 years. So in the course of that time, so many interactions, all of them meaningful, and just, I can't pick one, but there have been many. I mean, and this is the nature of medicine, because and nursing, I call it, we're at the sharp end of the stick. So we're taking care of patients in real time, and I'm a clinician, so there have been a lot of interactions over the course of time that have had meaning to me and to my patients.
Yeah. Wow. I mean, that's great. Really, that's how you said that's the whole point of medicine, is you're going in, these people are giving them their life for however long, like this for the surgery, or if they're in the ICU, for as long as they stay there. And it is your job to make sure that they come back with the life that they wanted, the life that they gave to you. So that's really incredible.
Anesthesia, I think, is anesthesia is unique, I think, in that sense that you are taking people who come to you in a certain state, and you expect to return them to their loved ones in exactly the same state, right? Surgery is kind of the same way too. If an orthopedist is working on a broken bone, you come to him with a broken bone. He says, "I'm going to fix it." He drills, puts the stuff together, and then hopefully it functions as well or better than it did before. I think that's true across the spectrum of medicine, that you are trying always to do that. But anesthesiology is unique in that we purposely take people from a state of consciousness to near death and then back again, and hopefully in the best of ways. So yeah, it's cool.
It's been described as like being the guardian angel.
Yeah.
You're,
Yes.
you're protecting them from the dangers of the surgery, and then when they wake up, they've been fixed. So
Yeah.
And you were talking about how you work in a pain practice, and that you've also worked in the ICU and are doing regular, I guess, regular anesthesia, quote unquote. Do you prefer working in the ICU or with the longitudinality of the pain patients, or with the quick little, I guess, bits that you get from regular anesthesia?
I think for me, my career path, it's not unusual compared to many other nurse anesthetists across the country have a very similar career path, because it is required of acute care experience before you can apply for anesthesia school. So, and the average nurse anesthetist, when they apply to school, has 3 to 5 years of experience in the ICU or in the emergency room or some acute care setting like that. They're all different. The ICU is a different type of experience. I personally, my wife worked in neonatal ICU for 30 years. I did pediatric ICU for 6 years, and it wasn't until I walked away from it to go into anesthesiology that I realized what a toll taking care of sick people and sick children in particular took. You don't realize until you step away from that sort of intensity the effect that it has on your mental health, your how you feel, until I walked away and then started to take care of healthy patients. So the first 5 years of my clinical practice in anesthesia was at LA County and UCLA. I was taking care of very sick patients. Did very complicated cases, anywhere from neuroanesthesia, orthopedics, liver transplantation. I took care of everybody in those settings. Trauma at USC, a lot of trauma there. And then in probably 1999, 2000, I went into the ambulatory care setting, and I was doing outpatient anesthesia, which was pretty much healthy patients. I've been doing that ever since. During the course of that, I was working with a pain management anesthesiologist who was boarded in pain medicine. I helped him in the pain management practice, and then also that became part of my practice. I like all of it. I like, there's not one aspect that I like maybe more than the other. I will say I don't like taking call in the hospital that I used to, being up all night for 20 hours and taking care of, really, really sick patients. I don't miss that. And certainly that's something for the younger set. I think when you have that young energy and you can stay up for 24 hours and do that. I certainly don't want to do that at this age.
I think also that the toll that it takes taking care of sick patients is greater on people who are younger or people who are older, or does it stay kind of consistent throughout someone's career?
I don't think that's necessarily any more difficult. I think that's the nature of it, no matter what you do. And the reality is, even in, young, healthy patients or, outpatients, anything can happen anytime, anywhere. And you always have to be ready. So I've always said, I've heard some people say, well, nurse anesthetists are okay for the easy cases or the uncomplicated ones. The anesthesiologist that I used to be partners with, he used to say, anybody who thinks that anesthesia can be either supervised or can be done from a distance hasn't practiced anesthesiology. The reality is anesthesiology changes minute by minute, second by second, literally. Patients can drop their heart rate at any moment. They can, and the person who is in charge of fixing the problem is the one who's at the head of the table. There's nobody else in the room. So the person who is at the head of the table, whether it's an anesthesiologist, a nurse anesthetist, or a dental anesthesiologist, or an anesthesiology assistant, those are the 4 different types of providers in the United States who deliver anesthesiology care. Whoever it is that's at the head of the table is the one who has to fix the problem. And so that's how I perceive of it. And it's always a challenge. And it doesn't matter whether the patient is 20 years old and totally healthy, or whether they're 80 years old and have multiple comorbidities. I am always, the hair on the back of my neck is up a little bit because I'm always ready.
Mm-hmm. Yeah, and you're kind of like, there's a stereotype with anesthesia is that it's just kind of laid back and you let them go to sleep and then you play Candy Crush or do Sudoku or like stuff like that. So clearly that's very much not real.
Oh, the reality is that, and I do remember people telling me that before I went into it. And for some people, they find, because it's, the thing that I heard once was that it's 95% routine and 5% terror. The 5% is when things are all going well, you've planned for everything, everything's going smoothly. The 5% is when the surgeon inadvertently sticks a trocar into the vena cava, or the patient has a herniated brainstem, or they get a pulmonary embolus on the table. It's that 5% of the time that you have to be prepared for at all times, and you have to have the algorithms in your head on how you're going to diagnose and treat problems.
Yeah, wow. And that's a good statistic too, is because really, like, the 5% is also unlikely. If you do your job correctly, if the anesthesia has been done correctly, most of the time, there, at least from my experience, there shouldn't really be a problem. But then, the patient might have like a past medical history of something that you don't really know about, and then boom, they have a PE, or the surgeon just kind of nicks how you said the vena cava. So
you can't predict that 5%. There are a certain amount of things that are predictable, and you have to do your due diligence to be as vigilant as you can to anticipate any potential pitfalls, problems, by making sure you do. The anesthetic process begins with the preoperative examination, and that includes reviewing all the labs, reviewing the patient history, doing a good physical exam, and then that lays the table for the preparation that you make in the operating room to decide how you're going to do the anesthetic. And you develop the plan of care with the patient and with the surgeon. You guys we all discuss what's the plan of care for the patient. And anesthesiology is a consultant role. We are not, these aren't our patients. The patients are admitted under the admitting physician name, and we're consultants to the patient and to the surgeon. So I don't own the patient. I'm their consultant and I'm their specialist. Just like if you had a orthopedic problem, you would go to an orthopedic specialist, and the orthopedic specialist would handle that problem. The orthopedic specialist isn't the person who's going to manage your diabetes, your hypertension, or your pancreatitis.
mm-hmm.
Their specialty is orthopedics. My specialty is anesthesiology. And so, I render all the knowledge and skill that I have available to make sure that the patient has a good, satisfactory surgical experience.
Yeah. What would you say to the aspiring CRNA who is just starting out their journey and is wanting to end up in your position?
Work hard. it takes work. It's not easy. The anesthesia training now is 3 to 4 years. It takes, you do your 4 years of undergrad in nursing, then you have to have a year to 2 years of experience in the ICU. So you're 5 years in before you get in, minimum. Most people, it's 5 to 7 years before they get into a program. And then you're looking at a 36-month program that requires everything. When I went to anesthesia school, they point blank told you, don't expect that you're going to be able to work part-time or do anything. When you're in anesthesiology training, education, you're locked in. So it's 3 years of 100% work, call, didactic, and clinical teaching. And, just be prepared to work. It's hard work. And there's a lot of responsibility. And some people just aren't cut out for it. One of the smartest people in our class, in my class in 1992, he was easily the smartest guy, but he couldn't handle the clinical aspect. Anesthesiology is a combination of education, knowledge, and the ability to apply that knowledge in the clinical setting. And if you can't move fast enough, think fast enough, and deal with problems quickly, it's not for everybody. So it's a unique skill set.
Yeah. And is the CRNA training basically like a residency after you get your like undergrad or your bachelor's in nursing?
It is. And I believe the new term for that's what they call them, NARS, nurse anesthesia residents. When I was in training in 1990, 92, it was, we were called nurse anesthesia students. Now they call them nurse anesthesia residents, and they consider it a clinical residency. Much like the clinical doctorate in nurse anesthesia now, you can do it either as a doctor of nurse anesthesia practice or a doctor of nursing practice, is very similar to a pharmacology residency. The PharmDs do essentially 36 months. And I believe that most of the programs have patterned themselves after that. My program when I went was 24 to 30 months, depending how much time you spent in your research component. And it's expected that nurse anesthetists during the course of their programs that they learn enough about, they do research, and that's a big part of their curriculum.
Yeah. I do want to start talking about an issue that's been popping up throughout the healthcare field, and that's the role of mid-levels and how their scope is changing. So have you witnessed any changes in your scope of practice during the time you've been a CRNA?
Well, I first want to clarify that term mid-level.
Yeah.
Because I think it's a term that's tossed about quite a bit. There is no, if you look in statute, that term doesn't exist.
Mm-hmm.
The term mid-level practitioner. The term mid-level practitioner has been developed by both policymakers and people outside of, I think, the domain of healthcare to sort of figure out how to handle people who aren't physicians, who are, quote, mid-level. And I always like to think of myself as a healer, right? I'm a healing practitioner. I'm a practitioner of the healing arts. That's what nursing is. That's what medicine is. That's what psychology and psychiatry. These areas, when we talk about dealing with the human body, the human mind, we're talking about people who are engaged in the process of taking people from not well to their optimum wellness. So when we look at the this term mid-level practitioner, you have to ask yourself, what does that really mean? Are these people providing, what is the service they're providing? And what is it? A nurse midwife who delivers a baby, you may want to call that person a mid-level practitioner compared to the obstetrician, right? But the reality is they're providing, what are they doing? They're providing their service and delivering babies. They do the same, they're delivering the same product. They may not perhaps cut tissue and do cesareans and that sort of thing, but on many levels, they're providing the same service for the community they serve. In the anesthesiology realm, the truth is that anesthesiology has developed since the mid 1800s, and it's been developed by primarily three practitioners: dentists, physicians, and nurse anesthetist. And we've participated in, nurse anesthetists have been part of the game since the beginning of anesthesia. I believe the first, you go back to the programs with Dr. Mayo, Agatha Hodgins was one of the first nurse anesthetists that published papers, and this is in the 1880s. Our history has been so well established that it is very, even though there have been times when physicians have tried to control the scope of nurse anesthesia practice, it's not been able to be done because we've been there since the beginning. And so, I always say, one of my teachers, one of my favorite teachers is Professor Chuck Griffiths at UCLA. He does research in pain medicine, as well as he's just this incredible guy, incredible lecturer. But he always told me, when I was learning from him, he handed me the same textbooks that the anesthesiology residents have. We read the same textbooks. We have the same didactic education. And he said, you just have to read this and know it. And you can't be any different than the physician that you're training on. UCLA, I was in my training. I was working, when I did my cardiac rotation, I did it with an anesthesiology resident. We did the cases together. We learned together. We practiced together. And when I got out, some of them became my colleagues, and we worked together at UCLA. So it wasn't, I have always said, people want to make a distinction. And I always say, you got to look at what the product is. On a policy level, as former president of the California Association of Nurse Anesthetists, I can tell you that there are times where it's a bit frustrating when, for example, an insurance company decides that they're going to pay the nurse anesthetist 80% of the rate that an anesthesiologist gets, even though I provide the same, they would be providing anesthesia for hernia surgery. I would provide anesthesia for hernia surgery, and I would get paid 80% of what they would make. I don't find that to be fair. But the insurance companies would say, well, we don't pay psychiatrists the same as we pay psychologists. We pay psychologists less. That's the argument. And these are policy distinctions and payment issues that are separate from this whole idea of what is the product that's being delivered, right? And as a healing practitioner, I don't care what the initials are after your name. Are you, one, licensed by the state that you're in to deliver the service? And if you are, and you're capable of doing it, then that's all that matters. And there doesn't have to be a distinction of you're higher or lower on the category. The idea is you deliver the service. And that's true for nurse practitioners. And in California is one of those states where they recognize that nurse practitioners provide a viable service that is billable, that is, you know, equal to or reimbursable as, say, an internist. Now, and most practices, nurse practitioners work alongside their internal medicine colleagues, and they're very happy. They all get along great, and they all have a good time. But, you know, if somebody were to try to, you know, to make a distinction that you can't provide that service or you can't do this, and that's why physician assistants, when you talk about being a mid-level, that is a layer of the scope of practice area where they do require, the law requires physician supervision of PAs, but they have a certain amount of autonomy in what they do, and they also are healing artists who are practicing within their scope and providing a service to patients, and they're all equally valuable. You know, I like to say that everybody who works in a hospital is important, from the person who's doing the environmental services all the way up to the CEO. Each and every person has a role, and each and every person, whether they realize it or not, has an outcome or has an impact on the outcome that patients have when they're in the hospital. If the environmental service person isn't doing what they're doing, then the infection rates go up. If the nurses aren't doing their job, you know, it's a cascade of events. Every piece of the puzzle is important.
Yeah. And by the way, I meant no disrespect in calling
No,
insane
no, I
level.
it that way, but I knew that this question was coming, and this is one of the things that I've encountered all through the life of my practice, and it isn't it's not new to me, and it's been around since, I mean, the real you know, the, if you want to call it, fights between the physicians and the nurse anesthetists, I mean, that's been on really steadfastly since the 1940s. And when I was president of the California Association of Nurse Anesthetists, first thing I did was reach across the aisle, talk to Dan Cole, who is the president of the California Society of Anesthesiologists, and said, listen, let's talk about what we can do together. We passed legislation together, and let's talk about our differences where we disagree. And supervision at that time was one of the questions on the table, and we had open, frank discussions. And he and I both agreed, and he was the chief at Loma Linda at the time. We both agreed that in our individual milieu, in the places where we worked, physician anesthesiologists and nurse anesthetists got along great. It wasn't until you start reaching up into the upper hierarchy of people at the higher levels of the professional associations who begin to try to control or dictate the course of practice. And, you know, that's something that the American Association of Nurse Anesthesiologists has never taken easily. We've always said that anesthesiology is the practice of nursing, just as it's the practice of dentistry, just it is also the practice of medicine. And it's just one of those things where we'll have to agree to disagree, whereas some physicians want to say, well, you know, it has to be a physician who's ordering it, dictating it. That's not really true. So, anyway.
So there's like the stereotype, I guess, is that they don't really, the nurse anesthetist and the anesthesiologist don't get along, as if like the nurse practitioners and the internists don't get along. Like they are providing the same service, but they're both fending for the scope, right? The physician is trying to, I guess, maintain their scope, and the nurse practitioner is trying to expand their scope. So it's just this weird kind of battle, I guess, between how do you not infringe upon the physician's like years of training and school versus someone who's like a nurse practitioner, not saying that they haven't done a lot of school and done a lot of training, but the physician path, I guess, just in the public eye is so much more vigorous than in the nurse practitioners
Right.
path.
And there's an argument to be made. You know, I've always said that the path is different, right? And you know, I wouldn't be one of those people who says that my education and my training is superior than my physician colleagues. I'm not in that position to say that because I've not gone through their training, right? The question becomes when we talk about scope of practice, and I had given you some resources on this. The reality is that the scope of practice for physicians was laid out long ago and in very broad terms. And you have to understand that things change over time. There was a time when only a physician could take a blood pressure, right? Because that was considered beyond the scope of a nurse to do a blood pressure. Now, things change over time, and medicine has changed over time. And I think that eventually it's going to, you know, there's so much that depends on the economics, right? The economics of healthcare, how, you know, who's, you know, the money's going to drive the action, right? To a certain degree. And can we provide the same level of care by, and I'll use your term, utilizing mid-level practitioners? Do nurse practitioners who I would, or even PAs, are PAs, do they provide a service, and can you lower the cost, like the number of internists that are around to take care of the patient population? I was in the Navy, and when I was in the Navy, we had corpsmen who had 2 years of training who were essentially, I mean, when you were out in the field, that was the healthcare you got. Now, granted, you know, most of the people in the Navy are young, healthy, and, you know, whatever, but each healthcare system has to decide, you know, how it can best provide the services that are rendered. And in the United States, so much of policy is driven by political action and lobbying. And, you know, that's the reality. That's just the reality. And, you know, the nurse anesthetist lobby is one of the most powerful groups in terms of for the, I mean, we have like nearly 40,000 members, and almost all of us are active in our professional association. We donate, we take care of things, and we're proactive in making sure that we're available to help the underserved. And that's the other piece of the equation. You know, at one point I had interviewed for a position at the most remote hospital in the United States up in Idaho. There's places all across America where physician anesthesiologists will not go. They don't want to live there. It's too remote. It's just not what they want. And that's part of the reason why, when you look at rural healthcare, nurse anesthetists provide nearly 75% of the rural healthcare is provided by nurse anesthetists. And it's just a question of numbers. And those rural hospitals have always been happy with our service. And this is going back 100 years. So it's a combination of economics and how are we going to, deliver the service.
Yeah. Do you think,
Sorry about that.
what do you think the future of the collaboration between, I guess I'm gonna keep saying mid-levels because I don't know what else to say. What do you think is the future between the collaboration, or I guess some people are concerned about the replacement of physicians by mid-levels. What do you think is the future between the mid-level and the physician? Do you think it's collaborative? Do you think they're going to have their own separate spheres? What's your take?
Well, I like to think it's collaborative, but I am the eternal optimist. And I am the one who reached across the aisle and said, listen, let's work on the things that we can work on together. So I've always been the eternal optimist. And, I mean, the supervision question is a very good one. And I'm going to bring up a little because I was part of that history. In the early 2000s, probably around 2007, there was this issue of opting out of supervision for nurse anesthetists, the Medicare requirement for physician supervision. California opted out of that federal requirement, which meant that nurse anesthetists could deliver anesthesia without physician supervision for Medicare cases and for CMS. And the Physician Anesthesiologist Society thought the sky was going to fall. They said, this is going to be the end of our profession. We're not going to, you guys are going to take over. And I said, it's not going to happen that way. In places where people want to work in a collaborative fashion, like UCLA, like USC, they'll do that. And the number of physician anesthesiologists at UCLA didn't go down. The number of physician anesthesiologists at Cedars didn't go down. The number of physician anesthesiologists at County didn't go down. But what it did do is it allowed them the freedom to eliminate supervision in certain sectors where they didn't feel it was necessary. Say the GI lab. And so that wherever they felt, based on the competency of their practitioners, that they could loosen up those supervision guidelines so that they could provide more service. Cedars-Sinai hired nurse anesthetists in the last 5 years. And prior to this, they never had them. And it was because they couldn't get enough anesthesiologists. Many of their anesthesiologists had left. They weren't pleased with the practice environment, whatever. And they wound up hiring, I think they have about 25 nurse anesthetists over there. The sky didn't fall. They still have physician anesthesiologists, but they're working together. Children's Hospital was another one. In 2002, I got called by Dr. Wetzel, who was the chief there. He said, listen, I want to start bringing nurse anesthetists here because I don't have enough residency slots, and he needed to staff operating rooms. So they brought in nurse anesthetists. There's no reason why we can't collaborate, and there's no reason why there's plenty of work. There's shortages of providers. As the baby boomers get older, the number of cases is going up, and the number of providers staying steady or going down. And for many, I don't know what the anesthesiology residencies are. For nurse anesthesia, the number of residencies has stayed pretty status quo. The number of people wanting to get into the profession has gone up because it's one of the top 10 jobs in the country. People, in terms of quality of life, income, and work-life balance, it's one of the professions where once you get through training, you really have, it's a good life. Yeah. And you get to help people.
That's the most important part.
So I hope it's not a problem. And I don't hear, when I used to work with physicians a lot, I used to hear them, say, they were worried. And I don't hear that from them anymore. And all the physicians I've worked with for the last 25 years, and I've worked with quite a few, they're happy. You know, I don't see any issues.
Have you seen the role of the physician change throughout your time as a CRNA, or has it stayed steady? Like, yeah.
Well, I heard some of my surgeon colleagues, especially my older orthopedic colleagues, say, "Oh, it's not like it used to," and they want to make us all Kaiser physicians. And I'm sure you hear this, right? You've heard, because for many people, they see the end of the private practitioner, the person who could bill the insurance, you know, and you know what they perceive as the money, you know. And I've always taken the position. I'm blessed because my father always told me, "Chris, pigs don't eat it." I grew up on a farm. Pigs don't eat it, and you're not taking it with you. So any money that you have, you should do good with it. You should share it liberally. And, you know, you can save for a rainy day, but you're not taking anything with you. So I was blessed in that money was never the reason I worked. Of course, we all work because we want to make a living. Everybody does, right? You got to do. It's never the driving force behind making a decision or why I chose one path or another. It was always about how can I be happiest in the position that I'm in. And for me personally, going into private practice 25 years ago was because I had reached a point in the team practice arena at UCLA, less so at County. I had more fun at County, but at UCLA, I was becoming a little not stifled, but felt that, you know, my skills and abilities weren't necessarily appreciated. That my physician colleagues felt that they, you know, I had physicians walk up to the patient and say, "I'm Dr. So-and-so and I'm in charge of this anesthesia." Well, that's not how it works. It really isn't. He may be he may be the leader of the team at that moment, but once I'm in the room and once we develop the plan of care together and I'm in the room alone, I'm in charge of that anesthetic. There's nobody else in the room. So, you know, I had reached a point where I had to go into private practice. So for me, that was part of it. But I see nothing but opportunity, and but I do see many of my older physician colleagues saying the glory days are over. And my response, I had a nephew who's in his third year at Tufts Medical School, and he's come and observed me in the operating room, and we've talked about, you know, the changing aspects of medicine. And I've just told him, I said, you need to go into medicine because you want to help people and that you like medicine. That's the reason to do it. It isn't because you're going to, you know, it used to be, I'm going to make $1 million and, you know, I'm going to be the highest paid person in the country. Right now, you can be a TikTok millionaire, right? You can, you know, there are people who design software apps who make much more money than you'll ever make as a physician. So if money is the driving force to be a physician, you shouldn't be doing it in the first place. The goal should be to pursue what you love to do, and then you never work a day in your life. And for me, I mean, I'm at the stage of my career where I'm doing things just because I want to. I work for almost next to nothing, and I help people when I'm there, and I go on mission trips and I help people there, and this is what I'm about. So, and this is a unique, you know, part of my life at this time, you know. So,
Yeah. And really the help that you give people is the greatest compensation you could ever ask for. Like the smile on their face, or the, like, those thank you letters that you were talking about.
oh,
Like,
yeah.
it's priceless. It's
Yeah.
priceless.
And I mean, and you've observed at the surgery center, so you see what it's like to deliver a regional anesthetic to a patient ahead of time and have them wake up from their, you know, your surgeon sticking, big trocars and drilling holes in their body, and they wake up and they act like they have no pain. They have no pain because you had the skill to deliver a really good regional anesthetic. Patient wakes up pain-free. They go home and they're pain-free for almost 24 hours. This is incredibly satisfying.
Yeah. And pain is just an awful, awful thing. Like, a lot of a physician's career is to try and take people's pain away. Like, if you're an internist, like people who come in with low back pain,
Sure.
like an ER doctor who's someone coming with chest pain or abdominal pain. Like, this is a very large part of your job, and it's like probably even a bigger part of what you do for regional anesthesia and pain management. So I never really thought of it like that. And that's a really great thing, you know?
Yeah, it's really true that, and it's very true that pain is probably, it's a thread that's woven through and through the fabric of medicine, for sure.
Yeah. You move your hand for a second. It's kind of blocking your face. Yeah, you're good. Another question about scope. Is there something that you are not allowed to do, but that you feel that you're qualified to do?
Potentially, I would say prescription. Prescriptive authority is a complicated question. Nurse anesthetists in the state of California, and each state has their own rules. In the state of California, a nurse anesthetist may not prescribe. A nurse practitioner may prescribe. A nurse midwife may prescribe certain things. Nurse anesthetists may only prescribe within the hospital setting or in the ambulatory surgery setting to the specific related to their to the operative process, right? So I can only do things within the surgery center. I cannot write a prescription for Zofran to give to a patient to go home for their nausea. And that's kind of silly because I can give Zofran in the operating room. I know what the indications are, the side effects. I understand all the pharmacology related to that drug. But because I don't have prescriptive authority in the state of California, I cannot prescribe. And that is something that our state association has looked at over the course of the last 25. I mean, this has been a football that we've dealt with for a long, long time. And we haven't decided to take it on because we knew it was going to be such a political fight. It was going to cost probably $2 to $5 million to take on, because there would be a fight from everybody and their mother that nurse anesthetists don't have the pharmacology education, the background to prescribe. The reality is that to prescribe, first of all, on the pharmacology end, our pharmacology that we receive in anesthesia school is the equivalent to what they get in medical school. And there's no question that on the pharmacy end, we are more than adequately trained. The issue is, are we trained enough in some of the things that are covered under that prescriptive umbrella, such as antibiotic prescription, and even those, we give those. And anything that I give in the operating room, I've been educated on. But like birth control pills, right? I don't know anything about that stuff. Certain types of medication that you would think of that might get prescribed. When you get a prescriptive authority, you have to be able to cover the whole blanket. And so in the state of California, it was never decided to go pursue that. There are times where it might be helpful. Say a patient gets a this is a good example. I'm doing an endoscopy. During the endoscopy, the patient develops They have a little bit of reflux of gastric contents during the upper endoscopy that splash onto the vocal cords. The patient develops a vocal cord irritation. Well, that requires treatment. You got to give steroids, you got to give, and there's an algorithm for treating that. Because I don't have prescriptive authority, it is necessary that I send them to an ENT for consultation. Whereas I'd be able to handle that myself as a routine complication of the procedure and just write them a course of steroids and whatever. But because I don't have prescriptive authority, I wind up sending them for a consultation, which is totally appropriate. It gets handled. But for the patient, it's definitely more inconvenient because the patient then has to go see they got to pay their consultation fee to the ENT. It's a separate visit, blah, 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 blah. And it's, may or may not be necessary because I know what the cause of the problem was, right? I was there. We all, right? So,
yeah,
but that's
prescriptions.
I can think of in my career where I felt like I was impeded. I mean, when transesophageal echocardiography came out, I immediately went into courses. I immediately went into the operating room with the cardiac anesthesiologist, learned how to do it. These are advanced skills. Same thing with regional anesthesia. I was always interested in it. I developed a proficiency in it. I teach it. I developed, when ultrasound came along, I became competent in doing ultrasound. Anything that I've ever wanted to do, I've always found a way to do it. The other issue may be fluoroscopy. I can't get a fluoroscopy permit in the state of California unless I do a 6-month course, which is more prohibitive than what a physician must do. A physician must take it's like a 10 CEU thing they have to take, and then they have to take a test. Whereas if I want to get a limited license fluoro permit, I have to go back to school for, I think it's like a year program. So that's the other limitation. Those are the two limitations that I can think of. And the fluoroscopy permit, I just avoided it by making sure that, I was if I'm doing anything that requires fluoroscopy, like, I do pump refills for intrathecal infusion. If I need to use the fluoroscope, I make sure that I get the physician in the room and he runs the fluoro.
Yeah. And prescriptions have been a big, I guess, barrier for a lot of providers, like optometrists before they could prescribe things, psychologists. Like that's the big difference between a psychologist and a psychiatrist, is the psychiatrist can give meds and the psychologist can't. Even like audiologists, they can't prescribe anything. Been a tool to try and keep that scope of practice, I guess, limited. So
And
do you, yeah, go ahead.
Aside of let's use the psychiatrist and psychologist example, the argument that the people who are trying to, and obviously the psychiatrists are trying to control the scope, right? But their argument is that we've gone to medical school, we have all this medical background that allows us to do that, right? So, I see both sides of that equation, but I just think they got to loosen it up because the psychologists are the ones that are oftentimes closer to the patient, closer to the problem, because they're the ones who are spending time doing the behavioral therapy and dealing with the trauma and stress and whatever it is, and getting down to the real roots of the problems, that they probably know better what the medication is that the patient needs, because frequently the psychiatrist is the one who doesn't really want to sit and do all that behavioral work, right? They don't want to talk to the patient necessarily. They just want to quickly rifle through and get them out the door.
Yeah, and then that's like goes into the problems of like the epidemic of people on antidepressants and like benzos and just the overprescribing. So yeah, that's another big issue that policy handle.
Yeah.
Could you repeat that? I'm sorry.
I said, that's a whole nother can of worms that does need to be taken care of.
Yeah.
And then
Speaking of
moving
policy,
back into the, what are we healing, right? Let's get to the bottom of it. So
yeah.
anyway, go ahead.
Speaking of policy, what have you, as the former president of the California Association of Nurse Anesthetists, what have you done? What policies have you made? Basically, you talked about how you bridge the gap between the physicians and the CRNAs, but that sounds like a very interesting experience, I guess. So could you talk more about that and what happened?
Mm-hmm. Well, I started practicing in 1994, and I told myself that I would give 10 years back to my profession in some capacity, that I would spend at least 10 years working on various issues germane to the profession. I had seen some people, God bless them, who spent their whole life, like their whole 30 years, they were actively engaged, very involved in the profession. And I knew that I didn't have that sort of stamina. I knew that I could do probably 10 to 15 years, which is approximately what I did. So I started out doing public relations. The public relations task that I developed was a program I essentially set up an easel and a video program to go out to all the junior colleges in the state and talk about nurse anesthesia and introduce it to them. In addition to that, we took that program and went to places like the California Plastic Surgery Association meetings, the Rural Healthcare Association meetings, and the California Dental Association meetings. The whole point of that was to expand our public knowledge about what it is a nurse anesthetist is, because a lot of people didn't know, right? The plastic surgeons mostly knew, the rural health people knew, but we were going there to thank them because they've always been very supportive of our practice. But that was the thing that I did on the Public Relations Committee. And then when I was president, probably the biggest thing that we worked, there were numerous things that were bouncing around. Some of them were insurance reimbursement issues. And then the biggest scope of practice issue was the supervision issue with CMS and Medicare, which began in 1998, culminated in 2002. And then I think we got the opt-out from Governor Schwarzenegger whenever he was in, and I want to say that was like 2002, 2003. And so I was active behind the scenes, in front of the scenes. It's amazing when you start looking at politics. And then on a national level, we were also lobbying on those issues, as well as Medicare reimbursement, for nurse anesthetists, rural healthcare pass-through, so that rural hospitals would get paid essentially a stipend to make sure that they could afford the anesthesia service. There were numerous things that I was involved in. I think it's interesting because, like, many of the people that I was working with at the time were people coming up in state politics. And, there's a thing that we say in lobbying, that you really got to start at the ground level. So, like, the best lobbying you can do is when the guy's running for the city council or the woman's running for city council. Get in there, help them, right? Help them early in their career. Karen Bass, who's now the mayor of Los Angeles, who's a former state assembly member, we knew her when she was a physician assistant running for city council for mayor. So the Nurse Anesthetist Association is very close to many, many people across the United States, because we are a politically active group. Barack Obama was a freshman assembly member in Illinois when we were walking his district trying to get him elected. Bill Clinton's mom was a nurse anesthetist. We have a history of being involved and trying to move the ball forward so that, one, patients can have access to our services, and two, that everybody realizes that we're part of the solution. I mean, our mission statement used to be, we're part of the solution for a healthier California. Nurse anesthetists, just by our nature, are proactive, we're team members, we're collaborative, and just basic nuts and bolts. The average nurse anesthesia salary is probably 200, 225. The average physician salary is 350 to 450,000. It's economics. There's no question that when you're taking care of Medi-Cal patients, nobody's getting rich. And the question is, how are you going to take care of all those uninsured patients? And frequently, nurse anesthetists are the ones who are at those hospitals delivering that care. That's the way it is. So,
Yeah.
so those things that I was involved in, some of the dentist stuff, there's currently some issues with dentistry that are going on. I'm on a low battery mode.
Okay.
Low battery mode. So I can either plug in or we can wrap up.
Finish this question. I got one more and then we can do whatever you want, really.
Go ahead.
Okay. So one of the arguments that people make against like mid-levels is that they make mistakes that a physician wouldn't, because the physician has a lot more training. What do you say to those people?
Well, I can only speak to my specialty because I don't know what the data is in other specialties, but I am very familiar with the data because in anesthesiology, because frequently that is the opposition has frequently said, oh yeah, if it weren't for anesthesiologists, nurse anesthetists would be killing patients. The truth of the matter is when you look at closed claims data across the board, whether, and it doesn't matter, tertiary centers, ambulatory centers, when you look at closed claims data across the board, the numbers are the same. There's one study that specifically studied OB in Oregon, where it was determined that the nurse anesthetists had a lower incidence of complication than the physicians. When you look at other M&Ms that I've done, that some people have argued support the claim that physicians had less of a morbidity and mortality, they weren't looking at enough numbers. I am waiting for the landmark study that should be done, and it should have been done by now, where we look at the states where they opted out of physician supervision and take those states and look at the morbidity and mortality data to really determine, does it make a difference? And, you know, I can tell you that, you know, the data does not support any of those claims specific to anesthesiology. And I would direct anyone to go and compare, and all you have to do is go to the American Society of Anesthesiologists and the American Association of Nurse Anesthetists, read the data, because they're both going to make different claims, right? I believe the data that I've read from my side of the equation. I've seen both sides, and there's no question that there's no difference. And then when you look at closed claims data from the insurance companies, there's no question. Bad stuff happens whether you're a physician or a nurse anesthetist. Doesn't matter. And it's interesting that even some of the more simple cases have some of the highest morbidity and mortality. I mean, monitored anesthesia care in GI centers has some of the highest incidence of problems, and it's because you're dealing with patients who frequently have unprotected airways. And that's true for physicians and nurse anesthetists. It doesn't matter who the provider is.
Yeah, and also in a setting like that, it seems that the anesthesia it's just easy. I guess easy is not the right word, but it's relatively low risk. So you're not as on top of it as if you were, let's say, doing cardiothoracic anesthesia. Like you're very focused because you know that just like a slip of the tube and the whole train is derailed.
Yeah, that's true, but I like to think that I'm always on it because, and you see me in, I mean, you see me in the operating room.
I don't doubt it.
I'm not off the ball
Yeah.
because you always have to be paying attention. I'm constantly paying attention. I don't, guys, and it's true. I've seen providers both. I used to work with a physician who would walk in the morning, and the first thing he'd do is set up his laptop on top of his anesthesia machine so he could track his stocks during the cases. And I'd be like, "What are you doing there? You can't be doing that. You're doing anesthesia here." And I've also seen nurse anesthetists on their phones during cases. It's like, you can't be doing that. You know, you got to be paying attention. So anyway,
Because you are their guardian angel. You can't
yes.
take that away. Yeah. So, moral of the story, I guess, is nobody's getting replaced.
Nobody's replaced. There's plenty of work to go around, and let's all get along in the sandbox. We all want the same thing. Everybody wants the same thing. We want safe patient care. We want jobs that make us satisfied and happy, and we want a reasonable income. And I think, unfortunately, for a lot of physicians, there are many who are worried about that final aspect. And the reality is, you're always going to make enough. You don't need to make more.
Yeah.
All right. I'm going to let you go, Alan.
I'm going to let you go. I'm the one holding you. All right. It was great talking to you, Chris.
No problem. Send me the final edit.
I will. Thank you very much.
Thank you so much.
Thank you so much for listening. I hope you enjoyed. If you don't mind, please leave a like and subscribe. And with that being said, see you in the next one.